Okay, everybody, we're going to start our webinar. This is our fourth webinar for the NLAAD 2018, Efforts to End the HIV Epidemic Nationwide. I am Luis Alberto Mares. I'm the Director of Community Mobilization Programs at the Latino Commission on AIDS. And today our presenter is Joanne Moore, Director of the AIDS Institute at the New York State Department of Health. Joanne Moore works at the AIDS Institute, that was created within the New York State Department of Health in 1983 to coordinate the state's policies and respond to the growing epidemic. The AIDS Institute is committed to eliminating new infections, improving the health and well-being of persons living with HIV, AIDS, sexually transmitted diseases, and viral hepatitis, and improving LGBT and drug user health. The mission can be concisely stated as follows: end epidemics, fight stigma, promote health. In its over 30-year history, the AIDS Institute has provided leadership in New York State, the national level, and internationally. Ms. Moore has been with the AIDS Institute for more than 10 years. In that time, she has been a leader in the development and execution of key policies that impact HIV, STD, viral hepatitis, LGBT health, and drug user health. Ms. Moore's professional and clinical experience is in public health and behavioral health, particularly within communities of color. She is a graduate of the National Alliance of the State and Territorial AIDS Directors Minority Leadership Program. In keeping with the theme, Extending a World Without AIDS, Ms. Moore is part of the key leadership of ending the epidemic. An ally and friend of the community, a collaborative leader, Ms. Moore has guided the state's efforts in a manner that has made the End the Epidemic initiative recognized as a program characterized by successful partnerships with stakeholders. Before we continue with Joanne, I just want to ask everybody to mute their lines, please. I cannot do it from here, so we avoid interference in the background. You can write your questions in the comment chat in the lower part of your screen, and this meeting is being recorded. So, Joanne, are you there?
I am here.
Okay, perfect.
Hi, it's Karen.
Thank you, and good afternoon to everyone. I think I'll just echo Luis's request. Please, if you would, just mute your lines because the line itself is not muted, so it's greatly appreciated. Just gives all of us a chance to be able to hear and to be able to respond. First, let me start by thanking Luis as well as the Latino Commission on AIDS for the opportunity today to talk about or continue our conversation as it relates to ending the epidemic. My understanding is that today, the expectation for those of you who have joined today's session is to understand some of the national steps that have been taken, as well as be provided with an update related to New York State. And I'm happy to do just that. The opening slide that you see here may be familiar to some of you. On the left-hand side are some of the key initiatives and activities that we have across New York State. And on the right-hand side are some of the different ways in which other states across our nation refer to the ending the epidemic activities within their own states and jurisdictions. Next slide. So while certainly I'm most familiar with the plan and implementation strategies of New York State, I do have the pleasure of working with many colleagues across our nation in looking at their initiatives, their programming, as well as their goals around ending the epidemic. For today's purpose, I wanted to just highlight a few of those. I should say that my highlighting these particular states are not because I'm involved in everyday conversation on the work that's being done, because I was able to gain this information through my participation in NLAAD, which is a national membership organization that works across our nation with all different states as well as the jurisdictions to look at how we can move forward, understand each other's best practices, and at the same time have discussions around some of the challenges that we may experience. I think what's key for me, and in some of the recent presentations in which I've been able to share the stage with other states, is that even though we often talk about the resources, and many times we talk about the frustration of a lack of resources, that even those states that do not necessarily have dedicated funding for ending the epidemic or resources in the way that in which we have seen in New York State, they too have come to the table in recognizing that ending the epidemic is a conversation that can be done by looking at their existing allocations, by looking at and reaching out for innovative ways in which they can gain some expanded funding, and by working across their communities to be able to develop a plan that fits within the framework and the resources that they have. So I think it's really key when you think about national interventions around ending the epidemic, that yes, it's a conversation of finance, but it's also a conversation of community mobilization, community leadership, and the willingness of partners to come together and plan effectively. Next slide. So in this example of Arizona, what you see is that Arizona has talked about victory through unity. And what they developed in Arizona is a comprehensive 5-year strategy that, quote, as they have said, would wipe out HIV across Arizona. The plan was created through their existing advisory group as well as the Ryan White Planning Council. It was guided, their framework was guided by the National HIV/AIDS Strategy as well as the Care Continuum. And it took over 2 years for the state to develop their plan. What they did, similar to New York State, was identify 3 specific areas of priority: testing individuals who are living with HIV yet not aware of their status, prioritizing and identifying those individuals who are out of care with the purpose of re-engagement in care, and increasing access to PrEP. So it sounds familiar, right? But it also recognized that within Arizona, a one-size-fits-all approach wasn't going to work, so there's a lot of regional work that goes on that looks at very specific, prioritized objectives and strategies specific to different regions across that state. Next slide. And just a reminder to everyone, if you would please just take a moment to look at your phone and make sure that your phone is on mute. Thank you. So some of you may be familiar with Marlene McNeese, who is out of Houston in Texas. Marlene and I had the opportunity during the recent United States Conference on AIDS to talk about the work that we're doing around ending the epidemic. And that was a really meaningful opportunity for me because this is where I really was able to give consideration to the fact of what I said in the beginning of my presentation, that sometimes when there's a lack of resources, what you do is you figure out how to work with what you have. And I think Texas has done a pretty incredible, or excuse me, Houston has done a pretty incredible job in doing so. And also, it's not about only finances, it's about policy. It's about political support, and it's also about community leadership. And certainly based on what Marlene has had to say about the work that's being done in Houston, Texas, community mobilization and leadership has been key in the partnerships that she has developed with her team. So in Houston, there was a grant from the Ford Foundation as well as AIDS United, and individuals or leadership across the city offered more than 30 recommendations that they believed would end the epidemic within the city of Houston. The primary goal is to decrease new cases of HIV by half over a period of 5 years, and they look to the 90-90-90 goals. They outline 5 core areas for both HIV as well as or communities who are not living with HIV but may be at risk. And similar to Arizona and also to New York, they talked about prevention of HIV, access to care for those living with HIV, social determinants, in particular from the presentations I've seen by Marlene McNeese, having honest and frank discussions of social justice and racial justice, criminal justice reforms, and public policies and funding. And the 5 areas that were described, a roadmap also makes more than 30 different recommendations and looks to draw on solutions that are based on interventions that are medical, policy, faith-based, focused on criminal justice, as well as education. Next slide. The next 2 areas I want to focus on are California, and in particular the jurisdiction of San Francisco, and then I'll talk about Washington for a bit. So in 2014, and I'm sure that you've seen a lot of the media, certainly San Francisco was innovative and early in their conversations of ending the epidemic. But in 2014, they established the San Francisco Getting to Zero Consortium. The short-term goal there was to reduce HIV diagnoses as well as related deaths by 90% from the current levels by 2020. So the plan called for 3 prongs. Again, it might sound familiar to what we have here in New York, and it really looks at some of the same areas that we do. Advocacy for access to affordable health care, respective prongs, including stigma, prevention programming, and HIV treatment programming. And then 3 specific or signature initiatives: the expansion of pre-exposure prophylaxis or PrEP, access to rapid ART or antiretroviral therapy, and retention and care. So the approach, it called, of course, for investment, and you see there the number of different areas or sectors that they brought to the table in partnership in order to leverage what they currently had as far as their resources. We certainly have been following San Francisco. Some of you may be aware of a recent release of their cascade in which they have reached the lowest number of new diagnoses in their history. And so what you see here is a jurisdiction that really brought together leadership, became innovative in their thinking, and similar to what I've said about New York State, started the conversation understanding that it wasn't a new conversation, it was a continued conversation to build upon the foundation that San Francisco had already achieved. The next slide focuses on the work that's being done in Washington. And they, too, in 2014, announced a proclamation to end AIDS from their governor's office. They worked with an HIV planning steering committee, and they had 5 specific goals that they intended to accomplish. They looked at the reduction of the rate of new HIV diagnoses by 50%. They looked to increase 80% the percentage of individuals who were living with HIV who were virally suppressed, reduced by 25% the age-adjusted mortality rates of individuals who are living with HIV, and reduce HIV-related health disparities among persons who are living with HIV, as well as improve the quality of life overall. What that steering group did was prioritize recommendations. They focused on their 5 stated goals, they focused on implementation strategies, and they looked at how they could complement, supplement, and expand, again, on existing efforts. The report actually makes 11 specific recommendations to end AIDS in Washington, and each recommendation has a series of action steps. As we know, and when you look at the blueprint for New York State, a focus on stigma as well as identifying and addressing disparities is significant to their plan. And they also have additional recommendations for the other areas that I've already mentioned. So I think what you see, if in the next slide, is that all of the Ending the Epidemic initiatives or plans, yes, there are nuance to each of the locations being states or jurisdictions, but sometimes even smaller than that, communities. But there are particular themes that certainly have been recognized in what creates or allows for a successful process. Each process does look different. It has to be nuanced. It has to be particular to the individuals, being served, the areas being served. It has to include community leadership and mobilization. Certainly we know in New York State how significant community leadership and community voice has been in ending the epidemic, as well as many other public health initiatives that we've seen. You have to include evidence-based tools that such as for HIV treatment and prevention, and they have to be leveraged. I'll talk in a bit about some of the work that we've done in understanding that every time we have a new intervention, it's not that it means we have to remove one of our past interventions. It means that we have something new to add to our options that we can offer to individuals. And plans do have some common elements: targets and goals, quantifiable, ambitious targets and goals. One of the reasons that Ending the Epidemic in New York State continues to move forward in a positive way is because we believe we've established consistent goals for all of us, regardless of where we sit within the state, to consider. Specific recommendations that speak to prevention, access to care and treatment, surveillance and data, addressing the structural and social barriers, and then ultimately strategies for implementation. And in the example of New York, what you know is that while there was a task force that developed a blueprint with significant recommendations on how we would end the epidemic, over the last 2 years, we also have held extensive opportunities for advisory groups who are representative of specific communities, who have lived experience, and who can speak from a place of expertise as to how recommendations have to be tailored in order to be effective within different communities. Next slide. So I want to focus on New York State for the rest of the presentation, and I want to talk about where we are. This is a timeline that has been shown on numerous occasions that helps for those who may not be as familiar to understand stepwise how we got to where we are today in 2018. And as I noted with the other states, I mean, I think that sort of the startup or the initial conversations happen in different ways, but more than not, in each of the examples that I shared, the conversation began as a community dialogue that resulted in community mobilization, that led to community leadership, and ultimately led to the endorsement and support of multiple partners in coming to the table to discuss and plan around ending the epidemic. In 2018, our focus is very much on implementation strategies. We have successfully implemented the majority, more than the majority, almost all of the recommendations within the blueprints. We continue to look for innovative ways in which we can sustain our momentum, as well as look to emerging issues. The dialogue and conversations certainly have continued to transform and be responsive across New York State based on the experiences that each region has been experiencing. Next slide. So when I talk about that in New York State, ending the epidemic continues to head in the right direction, it's not a new conversation. When you look at this slide that represents persons who are newly diagnosed with HIV, according to residents being New York State, New York City, or rest of state, what this continuum from 2007 to 2016 shows you is a consistent downward trend. The significance of ending the epidemic is seen between 15 and 16. From 2007 to 2015, while most years we experienced perhaps about a 2% reduction as far as newly diagnosed individuals, from 15 to 16 we experienced a 9% reduction. So what that says is that ending the epidemic did as it was intended by community leadership. It was intended to re-energize, refocus, and reignite the work that we were doing around ending the epidemic. When you look at the bottom line or rest of state in purple, it's significant to understand that while the line does not have the same downward trend, it does not mean that there is not as much success or achievement outside of New York City. We have to remember that New York City represents 75% of individuals who have been diagnosed with HIV, while the rest of state represents 25%. So first, that shows you that the numbers of individuals are significantly different. Second, when you look at rest of state, you can't do a year-to-year comparison to determine whether or not things are headed in the right or wrong direction, if you will. You have to look at multiple years over a period of time due to the smaller amount of individuals that are being considered. So I say that to say when you see slides that look like this, it's important to understand that the image that you see does give you an overall framework, but there are a lot of nuances that have to be taken into consideration to truly understand what the numbers and statistics and surveillance mean. Next slide. This slide is representative of significant policies that we have been able to move forward in New York State. I think similar to the last slide in which we continue to see a downward trend, a lot of what has to be recognized is that there were significant steps taken. One, in our prevention efforts. If you think, for example, about some of the innovative programming, such as, for example, home test kits. So over the last 2 to 3 years, we have piloted, along with New York City Department of Health and Mental Hygiene, the opportunity for individuals to be able to access, according to eligibility, a home test kit. The reason that it was done as a pilot is because we weren't sure exactly of what the success would be or what the interest would be. What I can tell you is that the interest has been beyond anything we had anticipated. The opportunity has provided itself not only to provide home test kits to individuals so that they can test within their home setting due to the fact they do not want to go to any of the testing sites that are available throughout the state, which is fine. But it also allowed for opportunities to talk about PrEP, pre-exposure prophylaxis, to talk about other healthcare issues and provide referral as well as linkage, and most importantly, to provide information and education to individuals as it related to all of the prevention options they may consider and or linkage to care if in fact found to be HIV positive. So that example is one policy example, but through the years, in support of the recommendations of the blueprint, we have also seen other significant policy shifts. In 1992, syringe exchange became legal within New York State. The opportunity of syringe exchange is probably best shown through the fact that in the 1990s, 56% of individuals who were diagnosed with HIV reported injection drug use. Today, less than 2% of those individuals less than 2% of HIV diagnoses are due to injection drug use. Now, what's significant is that in the midst of the opioid epidemic, which in my opinion is not an emerging epidemic, but is one that certainly in the last 2 years has garnered a lot of attention, we see that there are other states who are reporting an increase in HIV diagnosis due to injection drug use. We are not seeing that in New York State as of today, as it relates to HIV. We are seeing that as it relates to hepatitis C, and I'll talk about that shortly. I want to go to 2017. 2017 shows PrEP for adolescents. In 2017, regulations were put into place that allowed for minors to be able to consent to both HIV care, if diagnosed HIV positive, as well as to prevention intervention, such as PrEP, pre-exposure prophylaxis, or PEP, post-exposure prophylaxis. The purpose behind minors having the ability to consent is not to suggest that a family or other supportive adult should not be a part of a minor's process in their health care. What it's for is for those minors who do not have that level of support to be able to still access care, recognizing that for many minors or young people who may be homeless, who may have run away, who may not be within safe settings, still need to be able to access prevention and care. And so that is why this opportunity was made possible with a change in regulation. In 2018, and I'll talk about this in just a moment, the governor announced the elimination of hepatitis C in New York State. And so we will be moving forward, hopefully shortly, with a process that will build upon the community's already significant work through a coalition that looks at elimination of Hep C, that's in support of a consensus statement that the coalition or community members had put together and presented in February of 2017, and that ultimately will increase the number of individuals who are screened for Hep C as well as treated and cured. Next slide. Viral suppression is a very significant part of our discussion as we talk about quality of care and access to care for individuals. I think what's significant when you look at this slide for New York State is that the comparison of 2014 to 2016 shows a continued upward trend. However, I also think it's important to recognize that in each of these different demographics, there are disparities. If you were to look in the bottom left under age 13 to 19, what you see is that the percentage of individuals virally suppressed within this age group are significantly lower than the percentages in other demographics or groups that are shown here. I would say the same for individuals aged 20 to 24. So when we talk about identifying gaps or we talk about identifying opportunities in which we can continue to think about innovative ways to increase access to care, increase linkage to care, and ultimately adherence to care for the purpose of achieving viral suppression, certainly looking at young people aged 13 to 24 is a significant place for us to focus our energies. I also want to make the point that a lot of times we suggest that there are particular communities or populations of individuals who are more challenging to engage in care. But I think as you see here reflected overall, based on how people identify within surveillance data, that there is the opportunity to link and engage and retain individuals in care, so long as we continue and look to develop environments that are welcoming, that are supportive, that are safe, and that are able to allow individuals to present who they are with respect and dignity, free of stigma and discrimination. Next slide. Here too, we look at viral suppression according to race and ethnicity. And I want to make the point again, the comparison of 2014 to 2016. We do continue to see the upward trend, but we also see those areas of opportunity. So for example, individuals who identified as being Black or African American, in 2016, viral suppression rates were at about 83%. Yet when we look at 2016 for individuals who identify as white, we see that in 2016, viral suppression rates were at 94%. And if we look to individuals who identify as Hispanic, we see in 2016 viral suppression rates of 86%. There is a disparity here, clearly, in which we need to continue to look for opportunities to, again, create environments in which individuals come in and feel engaged and welcomed enough to want to retain in care. I do want to make the point, if you look to individuals who identify as Native American, it is the one area within our viral suppression slides that I presented today where you're seeing a downward trend. That in 2014, viral suppression rates among individuals identifying as Native American were at 99%, and at this point it's at 81%. So what that means is that we have to look at what opportunities we have to work within communities and work with individuals who identify as Native American to, again, increase the ability for individuals to retain in care. I'd just like to remind everyone again, if you would just mute your line, that would be greatly appreciated. So just take a moment, look at your phone, and make sure that your mute button is on. Next slide, please. So when we talk about viral suppression, certainly we know everyone is talking about U equals U, or undetectable equals untransmittable. And here too, the Department of Health was proud that in September of 2017, our Commissioner of Health submitted a letter to both clinicians as well as community-based organizations in which the department endorsed the Prevention Access Campaign consensus statement. I'm just going to ask everyone, please, if you could mute your line. Thank you. And so the consensus statement at that time indicated that an individual with a sustained suppressed viral load could not transmit the virus sexually. And this is significant. In the time since our endorsement, we know that internationally many other countries, as well as cities and states across New York State, have also endorsed the U equals U statement. What we have to look at here is significant opportunities that we have for us to, number one, engage in education of U equals U. I'm sorry, but does everyone hear an echo?
1 second, please.
A lot of echo.
People that just log in, please mute your line with causing echo. Hello? Oh my God.
Well, I'll keep going. Okay. Clearly, a priority there is to recognize, number one, continuing to enforce the importance of quality of health for individuals to maintain care, to achieve a sustained suppressed viral load, and second, the significant opportunity that we have to reduce stigma. Recognizing that for individuals who are able to achieve sustained suppressed viral load, this is significant into their life and to their life story. I have had the opportunity when I presented publicly to hear from many individuals who are living with HIV, have a suppressed viral load, how the research and science that has shown that they cannot sexually transmit the virus has positively impacted their life and the life of their partner. Now, also included within the letter from the Commissioner is the recognition that we need to have continued science and research as it relates to the ability of I'm just reading the messages on your line. But we have to look for the opportunities of continued research and science as it relates to opportunities of transmission through breastfeeding, as well as injection drug use. But for today, New York State Department of Health clearly has endorsed that U equals U, undetectable, untransmittable, and that an individual with a sustained suppressed viral load cannot sexually transmit the virus. Next slide. I want to take just a minute to talk about our work as it relates to hepatitis C in New York State. As I mentioned earlier, the governor, again, in follow-up to community leadership and community mobilization, has publicly announced that New York State intends to endorse a national strategy, our nation strategy to eliminate hepatitis C. This builds on significant policy steps that have been taken by New York State, including the hepatitis C testing law, which mandates the offer of hepatitis C screening to individuals born between 1945 and 1965. But what I want to show you is a comparison of 2012, 2015, and 2016 data is if you would look to the left of each of these line graphs, look to the navy blue bars, and look and see at the difference between 2012, 2015, and 2016. What you see is that in comparison of 2012 to 2016, a significant increase in number of individuals who report to inject drugs, and can you still hear me, Louise?
Yes, I hear you.
Okay. All right. Thank you. It's to the significant increase of individuals or persons who inject drugs and who are also diagnosed with hepatitis C. So what we found is that we have an increasing number of individuals with hepatitis C. They tend to be young, and they tend to be identified as white individuals who do have active injection drug use. So what does elimination of hepatitis C in New York State mean? What it means essentially is that it brings together, again, partners to the table. We look at what's existing. We look at the initiatives and the programming that we have, access to screening. We look at surveillance, and we look at the opportunity for us to build upon existing programs, identify gaps in care as it relates to individuals and doctors to be able to provide treatment for hepatitis C. It looks to increase and expand on education and awareness for individuals to understand that we have a cure for hepatitis C. And in having a cure, that means that we have an opportunity for individuals who are currently living with hepatitis C to become HCV-free. It is important to understand that the cure does not mean that the person cannot be reinfected. But what it does mean is that a person can still, again, have access to care. The next steps as it relates to elimination of hepatitis C will be the announcement of a task force, similar to what we did for ending the epidemic. Those individuals will continue to build upon the recommendations and consensus statement of the Community Coalition as presented in 2017. And we will continue to look for opportunities to build upon and expand upon existing initiatives, provider care network, and education and awareness. Next slide. So what's significant to me in the Ending the Epidemic blueprint for New York State was that the task force members took into consideration that the 3 points of the plan focused on testing, linkage and retention and care, and increased access to PrEP or pre-exposure prophylaxis could not actually be achieved if we did not consider a fourth point. And the fourth point is what looks at social determinants and opportunities for us to respond to the major barriers that most individuals have reported as preventing them from engaging in any of those aspects of prevention and care. Within that fourth point, it certainly speaks to drug user health, as well as continued interventions that build upon our long-standing history across New York State for harm reduction. So since that time, you see here information that relates to syringe exchange. It speaks to our increased access to naloxone, which is a life-saving drug for an individual who may be experiencing an overdose, and increasing opportunities for providers to be trained in the distribution or prescribing of buprenorphine, which is a medication-assisted treatment that offers opportunities to individuals who may be ready to accept that level of treatment. In the last 2 years, we have developed and opened 12 hubs. And if you're familiar with New York State syringe exchange programs, then what you know is that a hub is an expanded syringe exchange program. The charge of a hub is to partner with different sectors of the community, including emergency room departments, law enforcement, family and other social support, as well as emergency response members, for the purpose of making sure that individuals are not lost in care, that individuals have a safe place to come so that they can be provided with education as well as options as to whether they are looking for harm reduction intervention or are seeking a higher level of care. If I could ask everyone to look at your phone and mute your line.
Everybody, mute your lines, please. We are causing interference. I should not be hearing my voice in echo. Not be talking while we are on the webinar. Let's continue, Joanne.
Next slide. So I wanted to take a minute to talk about the Health Equity Initiative. Certainly, as I mentioned before, when we talk about that fourth point that looks at social and structural challenges that many individuals experience, it's very important for us to take into consideration how we build health equity within the work that we do. As I pointed out in my examples of viral suppression, while certainly we can see the successes as we saw an upward trend in many of the different communities and among many different individuals, we also have to balance those successes with the understanding of where our challenges lie. And if we consider health equity, if we take into account the identified areas of disparities as well as the social determinants that oftentimes are not necessarily addressed for individuals, that certainly takes away from, one, the opportunities for us to be able to engage individuals in quality care, which certainly leads to a higher quality of health and a higher quality of life. But two, it undermines all of the investment that we're doing. So, within the AIDS Institute, we have developed a health equity initiative, and the purpose here is for us to be able to look at what we are doing within the organization as it relates to health equity, and so that means looking at our strategic plan, looking at our current initiatives, looking at the request for funding proposals that we offer to partners across the state, and ensuring that all of the work that we do is done through the lens of social justice, of equity, and with the intention of building higher quality of care, regardless of what the setting is, regardless of what the service is. So I put this slide here because I think it's about, number one, it's about accountability, but it's also about making sure that in all of our conversations of ending the epidemic or any public health initiatives that we promote, that we understand the promotion of health equity has to be among the foundation in order for us to be able to achieve all of our other goals. Next slide. And so one of the last slides I wanted to present is so that way today's conversation just doesn't end once our call ends, but that you have the opportunity to continue to stay informed as far as our data, our surveillance, our achievements, and where we still continue to have to look for priority and and focus some of our attention. The Ending the Epidemic dashboard was intended to provide this information to everyone. So this is a public-facing dashboard. It provides information both for New York State as well as for New York City. And what it does is give you really as close to in real time as possible, based on the availability of our surveillance data, information that you can use so that you can determine within your own communities, down to the zip code, how it is exactly that we're doing in ending the epidemic. I think what's really significant, and we're working to continue to build upon the information that's available within the dashboard, is that when you talk about ending the epidemic, yes, there was a goal that was established early on that looked to significantly reduce HIV infections as well as HIV diagnoses in New York State. And that goal was to go from about 3,000 annual diagnoses or infections to 750. And I think it's significant to set a goal and to have sort of a common focus, if you will. But it's also important to understand all that leads to the achievement of that goal. And so we are going to be adding additional metrics to our Ending the Epidemic dashboard that looks to many of the areas that I talked about on today's webinar, including, looking at things like viral suppression and looking at indicators as far as individual and community outcomes, looking at opportunities around health equity and how we can continue to move that dial forward so we can ensure that while we're ending the epidemic, that we don't leave any particular community or population behind. So, the other piece that's significant on the dashboard is that there's an opportunity to provide feedback and information, and any of your ideas are welcome. So as we move closer and closer to 2020, I think what we found is that, it didn't just start with a conversation in 2013, and those were the sort of partners at the table, and that's how we're going to end. Our partnerships have grown. We have found opportunities to be able to gain and maintain consistent input from a number of different partners who may not have been in the original conversations, and that's what makes Ending the Epidemic so dynamic. I think what it does is it offers us lessons that we can learn from, as well as opportunities that we can grow with. So on that, I'll go to the next slide. And I'll say thank you. I know that today for some of you with some of the background, it may have been a bit challenging, but you do have the slides, and certainly there you also have my contact information. I'm always happy to, to talk or to provide any additional information that I can. I want to say that when I look at these images, it's very clear to me that the work of ending the epidemic is not done within any particular building or any particular place. It is done by a consortium, if you will, of individuals and of agencies that truly have come together to partner to make a difference in the lives of so many people. What we have done here, I think, is extraordinary. And when I say here, I mean not only in New York State, but across the nation and even across the globe, in that we brought together individuals who, each of us by ourselves can only do so much, but together, I truly believe we can end the epidemic and that we have no limits. So I thank you to everyone for your patience today and for being a part of this webinar. I'll turn it back to Luis, and again, thank you.
Thank you very much, Joanne, and I apologize to you and to everyone for the technical difficulties. For some reason, I wasn't allowed to mute everybody today. If I did it, I wouldn't be able to hear Joanne. So we have this problem. I really apologize. So there was a question, Joanne. Somebody asked when you were talking about the changes in the viral suppression levels, that what happened to the Native American Indian population, why it went down?
I don't know that we necessarily have all the right answers there. I think what we have done is we have reached out to some of our partners so that we can take into consideration what some of the reasons may be. The 2017 data has not been released yet, and I want to say that there too, you will see once it's released, most likely in December, that we will also have a conversation as it relates to diagnoses. So in some cases, it may be about access. I think that our partners who are experienced and have lived experience are able to walk with us and offer us some insight. We are looking, again, when you have opportunities like this and identify areas of concern, you have to also consider allocation of funding, and we are looking at that as well for us to be able to try to reverse the upward trend that we're seeing. and create environments where people will come into care. So I think there's more to come. I don't have all the answers on that, but we are in active conversation in order for us to understand and to reverse.
Thank you. So does anybody have a question? I think you can talk since everybody's on mute, or you can write it on the chat box. No, there's no noise.
Hi, Luis. This is
Yes.
Stephen Barnes from Houston. Joanne, you mentioned how one of the similarities is that we have community involvement. I was looking at the San Francisco slide and mentioned all these partners that are involved. I didn't see people living with HIV specifically named there. My assumption is they were definitely involved, but I just wanted to get your feedback on that part.
So if I understand the question correctly, is what is my awareness as far as persons with lived experience involved in ending the epidemic models in the different states? Am I right? And you asked specifically about San Francisco. Right. Yeah. So my experience is that definitely, and again, I'm not hands-on in each of these areas, but based on my conversations with some of the different leaders from those communities or jurisdictions, is that there definitely is community voice. I will also say I think there are some states who have attempted to develop ending the epidemic plans without community voice, and it very quickly became apparent that not only was that not acceptable, but that it wasn't going to result in necessarily a successful plan. And again, I think the evidence is shown through those jurisdictions and states that have had significant community leadership, community voice, and community input into the process.
Thank you. Anybody else? Any other questions for Joanne? Can you further explain the co-crisis between HIV and hepatitis C in New York State, specifically factors that have contributed to the uptake in rates and what can be done to reduce rates?
Sure. As I understood the question, it was to talk about sort of the co-occurring between hepatitis C and HIV and what's being done in response to that. Am I correct?
Yes, I think so, yes.
Okay. So I think what we're seeing, so what's significant about looking at hepatitis C elimination is that historically the resources that we had, we were only able to allocate to initiatives that looked at individuals who are living both with HIV and experiencing an HCV. What elimination will do is allow us the opportunity to expand our programming so that while we will continue to look at individuals who have the co-occurring diagnoses, we can also work with individuals with hepatitis C only. As far as the numbers, we do not have an exact number of individuals who are experiencing both. But again, I think what's significant is that within our care environments, that we're creating environments where individuals who are living with HIV who may experience a transmission of HCV can receive care, can receive screening and care as quickly as possible. Again, I think that there's a lot of discussion, certainly we know, as it relates to the cost of hepatitis C medication, but we continue to have increased opportunities and increased options as it relates to medical care and cost. And with the initiatives that we hope to move forward, with the support of the administration around the announcement of elimination of Hep C, we will continue to see a downward trend in that co-occurring history that we've had.
One more question. What are your thoughts on the development of a national plan to end HIV? I have not heard about any invitations for input from the public. I know advocacy to promote community input is being done, but nothing on whether these have been taken up.
Sure. So what I can say is I think, as everyone knows, we have an existing national HIV/AIDS strategy that's been in place for some time now. Many participants on the phone may have, in fact, also participated in a process called the Integrated Plan, which was intended to look at individual states as far as their planning related to next steps around prevention and care for HIV. In New York State, we already had an established blueprint, so the integrated plan is a reflection of that, in fact. At USCA, there were significant conversations that looked to community input as well as community work that had been done on the proposal of a consensus statement that would look to what areas of the existing national HIV/AIDS strategy should be updated, what additional areas should be included, and what areas of concern there were in general as far as making sure that access continues as it relates to funding allocation and eligibility of what services could be paid for with that funding. So there definitely is a very strong community coalition that's in these discussions. I believe that there are also opportunities to provide input on the most recent draft. And Luis, if you don't have that information, I'm happy to connect you with some of the community leadership that's responsible for taking on that activity, and then you can share that further.
Perfect. Thank you very much. Okay, everybody, thank you very much. And once again, we apologize for the inconvenience caused by the technical difficulties. I apologize to you also, Joanne, and thank you very much for sharing all this incredible information with us.
Thank you. Thank you, everyone.
Thank you.
Bye-bye, everybody.
Bye-bye.
Bye.